Okay, I'm going to go over to my next guest on the Rehab Power Hour today, to Brian. Can you guys hear me?
Yes.
Yes.
Great, great. So if you guys wouldn't mind, maybe start off by just introducing yourself. Tell me who you are and where you call from.
I'm Brian Keogh. I come from North Kingstown, Rhode Island, and heard about your product, and I wanted to learn more about it.
Very good, very good. And who do you have there with you?
Yeah, I'm his wife, Patricia.
Very good. Okay, Patricia, thanks so much. Very good. So, Brian, tell me a little bit about you and your past, because we were chatting a little bit beforehand. Tell me a little bit about your rehab experience to date.
The rehab has been going pretty good. My PT is very good for my legs. My arm is not cooperating as much. I do have, a lot of swelling in my hand and into my arm, but it goes up and down during the day. But I can move my fingers quite a bit. They all work. They just don't work well enough.
Sure.
He's in a lot of
Okay,
pain.
so
Painful.
oh,
He only
okay.
he only had the stroke 3 months ago, and he was told the other day at rehab for OT that he isn't meeting the goals in order for his hand, and that they may have to suspend his PT, his OT, after another 8 weeks. So that's what's kind of was the impetus to look into this Motus Nova piece of equipment.
Sure. Well, Brian, Patricia, tell me, so 3 months ago you had your stroke. Which side is it affecting you right now?
The right arm, right leg.
Okay. And do you happen to know if you've had a thalamic stroke?
No, it's systemic.
Ischemic stroke?
Yes.
Okay. Do you know where that ischemic stroke was?
Right, the lower.
So it's on the left side.
The lower back on the left side.
Well,
okay.
Let's put it this way. We've been to a stroke neurologist, and we've also been to a stroke surgeon. And they can't tell us why he had the stroke or how, and where the stroke is. The fact that it's affected his right side is very odd. So we don't really have, we don't really know, and no one can tell us anything about the stroke. And he did have a stroke many years ago, obviously, that didn't affect anything.
I had a stroke on the right side, didn't affect my left.
So.
Okay. Well, let's, we can maybe help provide some clarity, guys. So with respect to strokes, so you said this one was on the left-hand side, is that correct? Kind of lower left?
Yes.
Correct.
Yeah, so really common then. So most strokes affect the opposite side. So in the part of our brainstem, there's what's called a decussation. It's a fancy word for crossing. So whenever you have the neurons in like my left side of my hemisphere are going to control parts of my right side of my body. So when you have a stroke there, it's of course going to have the most impact on that right side. There's some really cool literature on the fact that it does affect the what's called the ipsilateral side too, but that's a story for another time. But the reason I asked if you had what's called a thalamic stroke is because you were mentioning pain. That's quite common with people who've had thalamic strokes, and the thalamus, that's where the name comes from, a thalamic stroke. Very, very common, I guess, in deep brain lesions. And so if you were having pain, kind of just led me to think if you were having a thalamic problem. Even still, if you have problems in the back half of your brain, kind of a little bit, our motor systems are forward and our sensory systems are in the back, that can also cause problems of pain. And it just bears a quick 1-minute description here. And pain is really, really interesting. I often find it's helpful just to kind of know things that can kind of help provide some clarity for you guys, what you're experiencing. And so pain is a really tough thing, right? It's of course a real experience that we all perceive, but pain is basically entirely done in our brain, right? We perceive pain in our brains. It's not in the actual place where it causes damage, for instance. And that presents a couple of complications. Most notably is if I have some misorganization, or there's normally sensory information that's going into my brain that tells me, for instance, that I am, let's say, moving my arm, or I'm experiencing cold or hot or pressure. Those things normally don't cause me pain. But if I've had damage to the parts of my brain that perceive sensations, and those things are being misinterpreted, that can then be perceived inappropriately as pain. So that's relatively common. So this, provided it's not actually associated with real, what's called tissue damage, like if I were to cut my hand, that's really what's called a central disorganization, or it's really, unfortunately, what's called maladaptive plasticity, which means that there's a plastic change in my brain that's bad. So not all plasticity is good plasticity, some of it's bad. And the way we kind of can get around this is we actually do a thing called desensitization training, where we do subtle movements or subtle exposure to things. Of course, it shouldn't be exceptionally painful. Just imagine this amount of movement you can do, and anything above this is going to cause pain. We want to kind of move right up until that point where it's going to cause pain, and with the hope then that our brains, just like we would try to reorganize our motor patterns, we would try to do that to then subtly increase that sort of perception, that sort of threshold for pain. So that's one thing that we should consider as well. But I want to jump over to your other really important topic that you wanted to talk about, and that is the finger mobility. Really good that you do have some volitional motor activity. Really, really good. In terms of the sort of discoordination that you're experiencing, maybe trouble moving, those things are very, very challenging to get back. But it is certainly possible. It does require a lot of practice. Like I was saying earlier with Andy, it's very much like you have to recapitulate all those learning steps again. And so we have to have that ability to have a training stimulus, a learning stimulus, for us to understand whether or not those movements that you're doing are good or bad. And a robotic system can help provide that objective reality, can provide that objective quantification of your movements and help you understand when things are good or bad. And so the way we actually improve this in the clinic or in the scientific world is we actually do these things called like precision motor control activities. And so we can do things like quantify how well you can move in fine sort of discriminated movements. And over time, you get better at that. And so what you have to do is you've got to effectively practice tracing lines, practice doing these really fine control motor activations where you're having to go up and down, control the pattern of flexion and extension, all these sort of things in a temporal domain. That's where it gets really tough, being able to control it in a fine temporal structure. So the reason I bring this up is it's not simply that I have to go pick up this cup of coffee and I'm done. The sequence of events have to be perfectly aligned, right? I have to perfectly extend my wrist, perfectly extend my fingers, and then grasp everything tightly at the right time. So there's a lot of temporal elements that you have to relearn as well, not just the range of motion and the strength, but you have to layer on top of that sort of precision motor control. So I think in terms of the Motus hand, it has those capabilities on the upper echelon. So it can, of course, help people like Pam earlier, who has those challenges on the other end of the spectrum where they're trying to increase range of motion and increase volitional control and strength. But on the top of that, we have the ability to turn things on its head and make it very, very challenging. So we do this by tailoring the games. We tailor the activities to make them much more challenging for someone like you, Brian.
Would it make a difference? I'm left-handed.
Sure.
My right hand is affected by this. So what would that, do with your theory about things to be done?
You mean talking about the mirror?
No, it's interesting. No, you're talking about does handedness impact the rate of recovery, and whether or not the dominant side is driving some improvement. So I think it's a really interesting one. And so if you look at the rates of recovery, the evidence is quite mixed. One might draw an inference that if, for instance, I had a right side stroke, I'm for writing, I am what's called right hand dominant. So I will write better with my right hand. I actually am a little bit ambidextrous, so I'll like golf with my left and bat with my left. But if I had a stroke on my right hand side, one would suspect that I would probably have less recovery of my left side. Just simply because I'm right-handed, I might just prefer to learn non-use and use my right hand. The evidence is a little bit mixed, actually. It turns out that if you have a stroke on your more dominant side, there could be a higher impetus for rate of improvement. So I think it's a bit equivocal at this point to know whether or not the dominant hand is interacting with the sort of ipsilesional control damage. So I think it's a bit interesting, and actually the story is even more complicated than that, because there's even some questions about whether or not there's a thing called dominant hand. It's really what it probably boils down to is that there's actually specialization. And so there's a really great scientist up at UPenn who has this idea that our hands are not dominant and non-dominant. They're just specialized in different ways. So we have one hand that's maybe a manipulator and one that's kind of a stabilizer. And the way you can kind of think about this, you can actually test yourselves at home with this, is go take a loaf of bread and go put the knife, the serrated knife, in the hand that you would normally choose to slice that bread. Okay, slice off a piece of that bread. Now switch hands and see what happens. What you're going to end up trying to do is you're going to just try to move the loaf of bread on. For me, I would try to move the loaf of bread with my right hand, because my one hand, my one side is the dominant side in terms of the dynamic side, and the other one's a stabilizer. So they're technically specialized in their own fancy way, but we'll just call them dominant and non-dominant. That's just a brief foray into upper extremity motor control that I don't know where that came from. But in any event, it's a really great question, Brian. And I think right now there really isn't a whole lot of evidence that one side is going to have a stronger rate of improvement than another side.
We were just interrupted, sorry.
No, that's okay. That's okay. So, yeah. So, what other questions do you guys have for me?
I don't know. You know, we don't have the robotic yet. We should have it next week. So I think once we have that, then I think in order to, I guess, fine tune what he needs to do.
Yep.
I guess we have to get back to you, but we're looking forward to.
Yeah. Well,
I mean, the thing is, he had the stroke ago, and you know,
my progression's been very good on the PT end.
Yep.
On the OT end, yeah, it's not. So
and he wants to get back to golf. So that's that's a motivator.
Yep. Very much so. Yeah. I'll have to have you teach me some lessons, Brian. I'm a terrible golfer. I'll go out there and try, but it's not pretty. But in any event, I think, 3 months out, you're very much in that subacute phase. I think now there's the best time to start rehab is now, I always say. If that's you who are 10 years post-stroke or 1 year post-stroke or 1 month post-stroke, I think the best time to start is now. So you guys are in a good place. Now, when we consider sort of the ROI, the return on investment of rehab, so if you imagine that early on, you could put in maybe 1 hour of rehab, and these are arbitrary numbers, by the way. If you put in 1 hour of rehab, you could get 10x in that first maybe month.
correct.
10 years down the line, in 10 years down the line, you can put in that same 1 hour rehab and you may not get 10x. You might get 1x or a fraction of an X, but that doesn't go to zero. And so I think it's this common sort of butted of heads of not being able to sufficiently drive rehab interventions in the clinic, right? Because we know objectively we're not giving enough rehab, period. There's no argument to that. And when you convolve that with the problem of, in order for us to continue rehab, which we're not delivering well enough, we have to show progress. Those things are actually antagonistic to each other, right? So it's no surprise that you and almost everyone else that I talk to in this sort of situation has the same sort of experience, right? We're like, well, we're plateauing and we get discharged, and like that's just a recipe for further spiraling, because of course you were destined to kind of, not destined to fail, but destined to not have a maximum medical recovery because the system is not designed to help people with neurologic injuries. So you guys are in no shape or form alone in this. I think almost everyone in your shoes has this kind of experience. So it's really unfortunate. I'm sorry for that, but we recognize this, and that's one of the reasons why we've made these systems to help you guys get this in the home. So I think this is a good time for you guys to be trying this. And while there's no kind of guarantees of recovery, but I think when we know kind of the main predictors, right? We do in fact know some of those main predictors. And when we're absent the perfect prediction about what your outcome can be, what we have to do is we have to take those things that are most important and try to maximize them. And those are the number of repetitions that we're doing, the active rehab, and the quality of that movement. Those things really need to be driven home to try to maximize and capitalize on the time that you have.
Thank you for answering our questions.
Thank you.
Of course. And I think as soon as you guys get the systems in-house, Love to have you back on, and we can work together one-on-one with that, doing an assessment to make sure we get off to a right start.
Wonderful. Thank you.
Very good. Okay. All right. Patricia, Brian, it's great to meet you guys, and I look forward to working with you guys very soon.
Us too. Thank you.
Okay. Very good.